For Health and Human Services started here. This is our first day and our first meeting. We've got a lot of new faces around the room. So we'll let everyone go around and first of all, just kind of introduce themselves. So we'll start down here with Representative Vaughn.
Hi everyone, I'm Representative Lindsay Vaughn, serving House District 22 in Overland Park. It's my second term, but my first term on this committee, and I'm really excited to be here. Thank you.
I'm Representative Carrie Barth for District 5, and I represent 4 counties, Douglas, Johnson, Miami, and Franklin.
Hey, I'm Representative Dave Beeler. I'm from the Leavenworth-Lansing area, District 40. This is my first term and my first committee meeting, actually, so glad to be here. Thank you.
Hello, my name is Representative Christina Haswood, representing House District 10 from Lawrence, Kansas. Happy to be back.
Hello, I'm Ron Bryce. I'm from District 11. Some of you may remember Jim Kelly, retired, so I'm happy to try to fill his shoes and happy to be here.
I'm Dr. Bill Clifford, District 122, which is 4 counties in western Kansas, about 3,200 square miles. Second year on the committee, but first biennium, so glad to be back.
Good afternoon. My name is Carl Turner. I'm in District 28, which is in Johnson County, the cities of Overland Park and Leawood. And it's my second term and my second term on this committee, and looking forward to it.
Hello, everybody. I'm John Epley. I'm on my 4th term. I'm from Northeast Kansas, the irregular part of the state, Atchison and Donovan counties. I back up my illustrious chair and try to keep her focused. So enjoy being part of the committee.
Big job. Go ahead, Representative.
Big job, right? Representative,
well, you know that.
yes. Representative Susan Freese, and I'm ranking on this committee, and I represent District 23 out of Johnson County, and it's Shawnee, Lenexa, and Overland Park.
Doug Blex, I represent District 12, live in Montgomery County and have 5 counties that go west. This will actually be my 7th year on this committee, and of which I didn't know a whole lot about and still learning. And I appreciate our chair, who's got a wealth of knowledge on issues that are pretty complicated. So I'm glad to be back. Thank you.
Hello, everybody. Brian Burkamp out of Wichita, Kansas. This is my 2nd term, but first being on this committee, so I look forward to learning more about this industry.
Representative Emil Berquist, the 2nd Berg on the Berg corner here, and 91st District, and that's North Wichita, Valley Center, a little bit of Valley, a little bit of Keachai, and Park City, and a little bit of Mays School District. So looking forward to working again this year. Thank you so much.
Good afternoon, Representative Brad Boyd, representing the 49th District, Olathe and Overland Park, Kansas. First term, first committee meeting.
Good afternoon. I'm Fred Gardner from Garnett, Kansas. I represent the 9th District, which is Anderson County, Allen County, some of Miami, and some of Lynn in East Central Kansas.
Ron Ellis, 47th District. I represent a little bit of Jackson, all of Jefferson County, and the western part of Douglas. And it only takes me 18 minutes to get to work.
I'm Representative Melissa Orpeza. I represent District 37, which encompasses Armadale, 1 Street in Argentine, portion of Turner, and then all the way out to 94th and State Avenue in KCK. First
and I'm Brenda Landwehr, and this is my 31st year, not consecutively, but 31st year in the legislature, and I represent the 105th District out of Wichita. And then I'd like to go around also on the table and have my staff introduce themselves. And I'll start with my committee assistant, our committee assistant, Dave Long.
I'm Dave Long. I've been...
Microphone, please.
Oh, I'm sorry. Mic, please. Oh. I don't do this very often.
I know you don't.
I'm Dave Long. I've been fortunate to be the committee assistant for this committee. This will be my 5th year.
Hi, I'm Leanne Thone. I'm with Legislative Research, and this is my 2nd year staffing this committee.
Elizabeth Cohn with
Legislative Research. This is my first year staffing this committee.
Scott Abbott with the Office of Revisor of Statutes. This is my 9th session.
How many years you been on this one? He doesn't want to remember. Go ahead, Jim. Yeah, he has to work with me.
Jenna Moyer, Office of Revisor of Statutes. This is my 8th session, and I believe it's my 4th or 5th year staffing this committee.
And for the committee members, I want you to know that these people sitting here at this table are the most important people for all of us. If you don't have answers and we weren't able to provide them, these folks will take and try to work on those answers for you. If you have any questions on things that are coming out of this committee or things that you haven't seen, please feel free to give Dave a call and he'll be happy to help you. I will also note that sometimes on some of these microphones, we have to almost eat them to be heard. So you may see us, motion to you or say something to you about moving them a little bit closer. I want to welcome each and every one of you here. This is, after an election, we don't really have a bunch of bills sitting here before us. So we're going to spend today with kind of a one-on-one with our hospital association and them introducing themselves so that you know some of the people that will be either just sitting in the audience, monitoring some of the things that we're doing, or actually presenting, or people that can answer some of your questions. Next week, we've got, 3 days of one-on-one on different topics. And for any of you, those of you in the audience that I have not contacted yet that would like to do a one-on-one for us, we would more than welcome it. Just take and give Dave a call so we can. And the other thing I will request is that you all bring, and I noticed the Hospital Association did, is an acronym dictionary for us. It's very important because that's the foreign language that we speak in up here. You'll hear us talk about HCBS waivers or what a CCBHC is, and you're like, what is that? But don't be afraid to ask. I will tell you that I am the queen of questions in the legislature, so I do not mind questions. So if you have one, make sure you feel free to ask it. My next order of business before we get into our presentation, are there any bill introductions today? Okay, and I might explain our bill introduction process is that when organizations or other people come to me and ask for bill introductions, I will ask them to go and talk to a committee member, one of you. I do not introduce bills. Is to talk to you. You will give the authority for them to visit with our revisor, and then you will also be introducing the bill in the committee when they bring it back to you. So I would highly suggest that when you bring a bill for an introduction that you do have some concept as to what that bill is, because that bill will 9 times out of 10 be coming right back to us to be heard, and I will be looking at you to be able to explain to us why we're doing that bill. All bills that come into this committee do not always get heard, so just so that you know that. If I don't have to have a committee meeting, I won't have a committee meeting. And that gives you some extra time to deal with other things that you have. And I know it's a luxury for our staff because we have to keep in mind that they staff a lot of committees because there's 165 of us trying to get their attention to do things. And Gordon told us the other day, I don't know, Scott, if you know off the top of your head, the number of bills that have already been requested, several hundred, 300 or 400, 300 or 400. Bills already requested. So just to give you kind of an idea. So first, I guess we start off with Chad Austin. And Chad and I go back a long ways. He's now, what is your title with the Hospital Association?
I am the president and CEO of the Kansas Hospital Association.
All right. Chad and I go back when he was in a little different position, actually in Tara's position, and we'll hear from Tara here in a little bit. So I just look at him as the same Chad that I've always known. But welcome to committee, and we're looking forward to what you and your staff are going to present us.
Thank you, Madam Chair, and thank you, committee members. As the chairperson indicated, I'm Chad Austin with the Kansas Hospital Association. We do appreciate the opportunity to be here today, to be a resource, to be able to talk about those issues, not only pertaining to hospitals, but also to healthcare. And so as the Madam Chair indicated, we did provide to everyone. Hopefully you have an acronym book. You know, one thing that healthcare is known for is to have many, many acronyms, and I'm sure you will notice that there will probably be a few acronyms items that we'll be talking about throughout this legislative session that may not necessarily be in that. So it is something that we constantly update and provide to not only our hospitals, but to our hospital trustees that we have across the state of Kansas as well. Our goal today is to really level set and provide some information related to healthcare and hospitals to give you a little bit of background in terms of how many hospitals we have in Kansas, the types of hospitals, those issues that are pertaining to our hospitals and items such as that. So not only will we be providing a little bit of an overview of who the Kansas Hospital Association is today, but we'll also be talking about those items that are top of mind for our 123 hospitals across the state of Kansas. But we'll also provide a little bit of information about the financial overview. So how do hospitals get reimbursed? How does the healthcare system work related to that? In addition, one of the key items that we've been hearing from our hospitals across the state deals with workforce. And so we wanted to spend a little bit of time talking about workforce initiatives that we're partnering on, not only with other healthcare provider groups and associations like who we are with the Kansas Hospital Association, but also non-healthcare related groups that we're working with to really try to attract as many people into our healthcare industry as we possibly can so that we can serve our community members throughout the state of Kansas. Lastly, we will be providing some information about federal issues. As you might anticipate, not only do we follow closely and work closely with the Kansas Legislature, but we do work very closely with our congressional members on congressional issues. Many of you are well aware of the Medicare program, and so with that, that is a program that really has a lot of influence and directives as it pertains to our hospitals with the patients that we serve across the state of Kansas. So to give you a little bit of information about the Kansas Hospital Association, wanted to share with you, we've been around since 1910, so we've been over in our state over 100 years. Our vision for the Kansas Hospital Association is optimal health for Kansans. Our mission is to be the leading advocate and resource for members. And each year, our KHA board, which is made up of 21 individuals, we do identify some strategic priorities that we want to focus on. And the 6 bullet points here are these priorities that our board has really identified for us to be intentional on and lean into. One of which is policy influence, as you might expect, is more on the advocacy side. So not only advocating with the state legislature, but also with Congress, but also with the agencies on the state level as well as on the federal level with the Centers for Medicare and Medicaid Services. Financial sustainability is another area, looking at reimbursement and that structure that's related to healthcare. Workforce, as I mentioned, is a key priority area for many of our hospitals that we're focused on. Looking at healthcare visioning. So one of the items I want to be talking about is looking at how can we be creative and innovative to look at different models of care to be able to serve our communities across the state of Kansas. And so I want to spend a couple minutes talking about that here later on in the presentation. And then advancing health, looking at population health, looking at health equity. What can we do to really lean into those topics to be able to serve the community members from our state? Now, I do recognize that this slide is very, very small print. That was not intentional, but it is something I just wanted to kind of share with you. The Kansas Hospital Association not only does a lot of work related to advocacy, but we do provide a lot of other services to our hospitals as well. So we do provide education, we provide group purchasing, shared services. We have a foundation that works with recruiting and supporting healthcare professionals. We also have a work comp program that we not only do for the hospitals, but for a few other industries as well. In addition, we partner with other groups, including our friends at the Kansas Medical Society, where we have a couple entities that were started in partnership and collaboration with them, one of which is the Kansas Healthcare Collaborative, where we're bringing physicians and hospitals together to really be more focused on quality initiatives across the state of Kansas to improve quality. In addition, we've worked with them on the development of the Kansas Health Information Network, which is more of a IT component of working with them on making that available to our hospitals across the state. Beyond that, you will also notice, I think, over the next couple of weeks, Kansas does work very closely with each other. And so not only do we work with the physician community, but we partner with many of the other healthcare associations, whether we're talking about the pharmacists, the long-term care community, the industries related to healthcare, whether it's the insurance companies. And so so you will notice that in Kansas, we do work very collaboratively with many of these other groups within healthcare, but we also extend that beyond healthcare, where we're working with entities such as the Kansas Bankers or the Chambers across the state of Kansas, or looking at the ag community, recognizing that healthcare is a centerpiece in many communities, and I'll be talking about that here in a few minutes. Wanted to share with you the hospitals that we have in Kansas. As I mentioned, we have 123 hospitals across the state of Kansas, of which 82 are critical access hospitals, and there'll be a definition related to that here in a second. We also have different types of hospitals, such as county hospitals, city hospitals, and district hospitals. In addition, we have for-profit hospitals within the state of Kansas. We have not-for-profit and religious-affiliated hospitals. And so a variety of different hospitals. We do have a lot of independent hospitals, and so that's something that we have within our state compared to, say, for example, South Dakota, which is very system dominated in terms of the makeup of their healthcare system and their hospital system up there as well. In addition, one of the items that we really strive on is that even though we have rural hospitals and we have urban hospitals, our hospitals are very interdependent upon each other. We work very closely with each other. Our healthcare system in Kansas would not be sustainable without that partnership and collaboration between our small hospitals and our urban hospitals as well. Just to share with you on this map, we do have 105 counties, obviously, in the state of Kansas. 10 of those counties do not have a hospital. 18 of those counties have more than one hospital. The remaining 77 counties have one hospital within their county. As I shared with you, there's a few different types of hospitals that we have within our state. We have what we call a critical access hospital, where we have 82 critical access hospitals. That is a Medicare designation for, in essence, a really one of our small rural hospitals that has less than 25 beds. There are certain parameters that they have to follow that's under the federal rules. They do get paid a different type of reimbursement under the Medicare program than what I would call the prospective payment system hospitals. The prospective payment system hospitals are going to be more of your large rural hospitals and your urban hospitals. So, for example, here in Topeka, Stormont Bell or St. Francis, or in Kansas City with the hospitals that we have there, or in Wichita with Wesley and Ascension. There's also teaching hospitals. We have one teaching hospital in Kansas with the University of Kansas Health System, and then we have a number of specialty hospitals that really focus and lean into a specific area that they're providing services to their community members. To give you a little bit of a hospitals at a glance as to how many staff beds and some of the statistics that we have in Kansas, on average, we have about 292,000 admissions that happen within our hospitals, over 7.5 million outpatient visits that happen within our hospitals across the state of Kansas, over 1.2 million emergency room visits, and as well as about 38,000 births that happen each year. Out of those 38,000 births, about 40% of them roughly are Medicaid basically births, in terms of being where the parent, the mother, is a Medicaid recipient. And so in essence, that's about 40% of the makeup of the 38,000 births that we have within our state. Wanted to kind of share with you a little bit about some of the health rankings as we compare ourselves to other states. And this graph right here, especially on the top left hand where it says overall health or Kansas health rankings, back in 1991, we actually rated or ranked 8th in the country in terms of our health ranking. Unfortunately, that has slowly declined over the years to where now we're in essence about the 25th to the 32nd state, depending on what ranking that we're focused on. One of the items that the Hospital Association Board is really wanting to focus on is to see what we can do to start reversing some of those trends. And so this past year, our board actually took up a new strategic aim from our perspective to be able to really focus on the improving the state health rankings with a focus on preventative healthcare services. And so looking at ways as to, what can we do to address obesity? What can we do related to smoking and tobacco cessation? What can we do to focus on improving cancer care within the state of Kansas? And so looking at ways that we can partner with each other among all 123 hospitals, but also working with our partners in other areas within healthcare, as well as those non-healthcare entities, to see what we can do to improve the health rankings within the state of Kansas. In addition, one item that we get asked about on a regular basis is health insurance. Right now, from our perspective, about 9% of the Kansas population is uninsured. When you look at the makeup within the hospital, like the patients that we serve, about 43% of the patients on average are Medicare, roughly 14% are Medicaid. Commercial makes up about a third of the business that we have within our hospitals. As the graph points out, we are one of 11 states that have not yet moved forward with the adoption of Medicaid expansion, but that is something that I know that has been talked about over the years, and we'll have an opportunity to talk about that at another point in time as well. One item that I did share with you that I wanted to really lean into is that from a hospital association perspective, not only are we looking at kind of what are the trends currently, but what can we do to really be creative and to ensure that we have the ability to deliver care in communities across the state that is sustainable. And one item that we've been able to kind of work with our federal delegation on, as well as a number of other partners, is this whole concept of a rural emergency hospital. In essence, if you think about it, a rural emergency hospital is a hospital that basically has access to emergency room services, access to outpatient services, but doesn't necessarily have inpatient beds. And so you have to have a pretty strong EMS system. You have to have a system in place where, in essence, you're able to provide that immediate care that's needed for community members. But for more acute care services, what you would do is work with a neighboring hospital or a larger tertiary hospital to send that patient to. This is a new concept that is just now getting underway on the federal level. It was passed 2 years ago with the leadership of not only our congressional delegation, but leaders within the state of Iowa as well, where starting in January of 2023, here in the last couple weeks, the federal government has started to identify rural emergency hospital as a type of hospital or a classification hospital that can be moved forward with the delivery model. We're still waiting for some details to be shared from the federal level in terms of clarity. Once that information is shared to our state, we have been working with the Kansas Department of Health and Environment, our state health agency, to be able to look at what the rules will be from a state level. Legislation was passed, I believe, 2 years ago by this body from the Kansas Legislature to adopt the rural emergency hospital. And so this will be something to ensure that if you're in a community where you cannot sustain a hospital with inpatient services, that this will provide you another model of care that may hopefully be sustainable and be able to meet the needs of that local community. So we're really excited about that. Kansas, as I mentioned, was one of 2 states that really led the efforts on this, and we were seen as a role model for many other states focusing on healthcare delivery. A couple other items just to kind of share with you in terms of some recent information that's been out there. Where we've been over the last couple of years has been very challenging, but we're very resilient within our hospitals. We're very pleased in terms of how our hospitals were able to respond over the last couple of years and be able to provide the care that's needed and necessary within their community. But we are seeing some challenges as it relates to workforce, just like I know other industries are as well. And so one item that we're seeing is, items related to temporary staff, and we'll be talking about that here in a little bit. We've seen wages increase, which I'm sure you've seen in some other industries as well. The expenses have been going up as well within our hospital community. And so cost of supplies, cost of labor, the inflation has really played a toll on some of our hospitals. And so we're doing whatever we can to be creative and innovative to ensure that we're being able to maximize the ability for us to be able to provide care within our local communities. One item that we do like to share with everyone is the economic impact of healthcare, but also the economic impact of hospitals. And this is something that we do on a statewide basis, on a yearly basis, and on a county-by-county level every other year, where we talk about the economic impact of hospitals and other healthcare systems within our industry. From a hospital perspective, we employ roughly about 100,000 people within our 123 hospitals across the state of Kansas. That creates an additional 94,000 jobs as well. So in essence, not only are we a healthcare anchor, but we're also an economic anchor as well. And so that's something that we like to kind of at least share with our stakeholders and other public interested individuals on that as well. With me today are a couple of individuals I would like to identify. We have Tara Mays, who I'm going to turn it over to here in a few minutes. Tara is our person that you'll see on the ground here and will be accessible with any questions that you may have. Also, Shannon Flock, who will be talking with you about some of the finance areas. Jaron Caffrey is our individual that has been focused on some workforce initiatives, so really excited about him sharing some of those topics. And then Audrey Dunkel deals a lot with our federal items as well as overall some of our government relations activities. And so I know I talk fast, but I wanted to go through as quickly as I could to be able to highlight some of the statistics, and just really want to express my appreciation for the opportunity to be here today and to serve as a resource to all of you. So please let us know. So I'll turn over to Tara.
In committee, you'll be able to ask questions once we get through all of this. The staff will do that at the end. And then I was negligent in letting the new committee members know we are a paperless committee. So you'll want to bring your computer with you because you can pull down everything that Chad was presenting. Dave has put out there on the legislative website. So that's how this operates. And the what? And the S drive on your computers? Is that the way it works? See, I don't know those things because I just rely on Dave a lot. But I just know that that's how we do it. If you feel that you want to print it off, then that's up to you if you want to bring it in printing. But we find being able to, because I think those are all done in PDF formats, so you have the capability then of making your notes right on there. Welcome, Tara.
Thank you so much, Madam Chair, and thank you, members of the committee. As Chad mentioned, I'm Tara Mays with the Kansas Hospital Association, and we know you're going to hear a lot today about some of the major issues and realities that really our hospitals are facing. But before we do, I want to give you just a little bit of context and maybe build upon some of the things that Chad said about what's driving the conversations around kind of policy issues at our hospitals. And one of the ways that we like to think about that is really kind of what are the key main areas that are driving all of the things that we're trying to work on in 2023 really and beyond. So as Chad mentioned, like a lot of other industries, the healthcare industry is really struggling right now to fill positions in both clinical as well as non-clinical settings, really to be able to provide the care that we know your constituents need across the state. But in addition to that, right now struggles, there are also challenges kind of in the pipeline and the future workforce that we understand we really have to address now so that we can mitigate future workforce shortages in key positions down the road. And you'll be hearing more about that from my colleague, Jaron Caffrey, a little bit later. The other key areas really is in the area of financial viability for our hospitals, which I think Chad kind of laid the groundwork for. Really, as a lot of other industries these last couple of years, there were always some fiscal challenges ahead and on the horizon for our hospitals. But these last few years, dealing with a pandemic really has meant a lot more burnout, but it's also meant more financial challenges were kind of maybe created in somewhat of an imperfect storm, so to speak, with inflation, as Chad mentioned, high wages, continually climbing, higher staffing and supply costs, and lower reimbursements that you'll hear more about. We're beginning to really feel the impact of the future financial viability of our hospitals. And then all of that is really impacting patient service, which is absolutely at the core of everything that our hospitals think about, not just on a day-to-day basis, but on a minute-by-minute basis, and how we provide care to your Kansas constituents, the right care at the right time. And this is really how I like to think about where do our policy positions sort of live and where do our proposals sort of live. So I'm going to highlight a few areas that we think that we are interested in kind of working with you all on and talking with you more about in future days. Of course, I want to talk just a little bit about streamlining of licensing and credentialing. You all have done some important work around the conversation around streamlining of licensure in the state of Kansas. There's also another component to that, and that is credentialing. And credentialing is something that really happens in a different way. Licensure, as you might imagine, is done through the process with the regulatory boards. Credentialing is done with each individual payer and requires each physician and clinical folks to be able to submit a relatively robust packet of information in to be able to be reimbursed from each individual payer. And that can be quite a cumbersome process. And we're really interested in getting these experts working quickly. So anything we can do to really speed up and modernize that process becomes critically important. Another area that I just wanted to highlight for you all today is prior authorization. That's defined in your book, your handy dandy book that Chad mentioned earlier, as a cost control procedure that requires a service or medication to be approved in advance by the doctor or the insurer. Without prior authorization, the health plan or insurer may not pay for the test, drug, or service and could result in an increased cost for the patient. Our hospitals are really now seeing that this is used in a fashion that is no longer cost controlling, but perhaps overall adding to the cost and also requiring our hospitals' clinical staff really to spend on average 1 to 5 hours per prior authorization to either be on the phone or standing at a fax machine rather than providing patient care. So our hospitals have reported to us having to hire some additional administrative staff just to simply accommodate what we feel like can be a somewhat burdensome and outdated process, having to submit hard copy forms via fax and sit on the phone, and really has some pretty significant impacts to patients getting the right care at the right time, and it's taking a toll on our healthcare workforce process. And so wanted to highlight that. Another key component that this committee and those of you returning may have heard about during the 2022 legislative session is protecting our workforce. One of the things that we really want to focus on is keeping those folks protected that are working on the front lines right now. KHA, we've surveyed our hospitals, and 46.2% of our hospitals report violence against their frontline staff. 71% of those are physical assaults and batteries on doctors and nurses. So what at one time was more of a concern for really the patients in crisis has grown and looks a little different. Now it's not necessarily those folks that are in the patient role. So we really believe that we must address protecting the nurses and physicians that work tirelessly to provide patients care in a setting where our hospitals cannot turn anyone away. And so last year, as some of you may remember, we worked on House Bill 2620, which increased the penalties around assault and battery of a healthcare worker and created the crime of interference with conduct at a hospital. And we look forward to talking with you all more about that in 2023. As we look at workforce, we know there is both a need to really stretch our clinical resources inside our hospital walls, but in addition to that, there's also really a need to have people out working and in the workforce, not sitting in waiting rooms or at healthcare facilities awaiting healthcare services. So one way that we strategically get at both of those things is through the strategic use of telehealth services. So returning members of this committee, you may have heard that there's a need to kind of ensure the parameters of telehealth can remain a viable option for Kansas-based healthcare providers and for your Kansas patients. And we think that there's some room to assure that telehealth remains an option if we can work with the legislature to assure for the more complex telehealth usage along the continuum of care. We create some fair payment parameters, as well as really creating a body in which we can look at telehealth services beyond just today. And one way that we would really like to do that is really beginning to put patients, physicians, payers all around the table with you as policymakers, because one thing that we recognize is telehealth came on very quickly in the last couple of years, and it's probably going to change and evolve a lot going forward. So having a body to make policy recommendations to you all, we think is a time well worth spending. I do want to highlight for you all one thing, a need for mental health observation program for patients that we know currently have been assessed and approved for involuntary inpatient stays at our state hospitals. Currently, those patients are waiting for those services inside our ERs across Kansas, and in addition to that, in our county jails. These patients are state patients, and there is currently no reimbursement mechanism for the time that our staff is spending doing just the patient observation portion of these services. So we want to work with the legislature to institute the recommendation that was made by the Mental Health Interim Committee to conduct a 2-year pilot to reimburse hospitals and some of our partners in police and corrections serving these state patients for the patient observation that we all are doing currently. Additionally, we want to work with you to ensure that patients continue to have access to the post-acute care services following their stays in Kansas hospitals. I think Chad mentioned, how EMS becomes critically important as we look to rural emergency hospitals. We want to make sure that patients are well taken care of once they leave our hospitals, whether that's when they go to a rehab or long-term care facilities. We want to make sure that they can get in and out of our hospitals in a way that provides them access to care. So in terms of financial viability, there are a lot of policy areas to be considered, including in the Medicaid program and expanding coverage, as Chad mentioned, but also addressing lagging rates that you're going to be hearing more about from Shannon, our team. The increasing costs around supplies and staffing are really key, we think, to financial sustainability for our hospitals. So with that, I will turn it over to Shannon, if it's all right, Madam Chair, to talk a little bit more about some of that financial lingo inside of your book.
Welcome to committee.
Thank you very much for having us today. Just to introduce myself a little bit, my name is Shannon Flock, and my background is actually I've spent about 15 years as a CFO and a CEO in some of our rural Kansas hospitals. So I've been in those shoes. I'm a accounting graduate from Kansas State University for all of you Wildcat fans, but right now I am also teaching Hospital Finance 101 for Wichita State University. So if anybody wants to join my class, I'm happy to get you signed up. So I thought it was funny they told me I have about 10 minutes to teach you about Hospital Finance 101 in something that takes me a whole semester to teach students. So we will try to do our best. Oh, what happened to my screen? Okay, so there we go. Okay, so I want to set the stage for how hospital finances is a little different from the private sector, actually very different from the private sector. What is similar to the private sector? We have a balance sheet, we have an income statement, we have a cash flow statement, and we also need to make payroll. Those are pretty much the similarities. Now let me talk a little bit about some of the difference in hospital finances. So I've just highlighted about 6 bullets here of some things I want to explain to you. So one, negotiating prices. So we can't just increase the price of our service to cover our costs. The price is really mandated to us by the insurance payers and what they are going to pay. So that is one difference. Number 2 is we really can't choose our customers based on a rule called EMTALA. And EMTALA is a definition in your book, but EMTALA is Emergency Medical Treatment and Labor Act. And pretty much what it says is you can't talk about payment, but every person that walks in their door, you have to do a medical screening for them and you have to stabilize them, no matter if they can pay or not. So we can't choose our customers, so that's number 2 difference. We're very limited on the negotiation part. I'll talk here in a little bit about government payers, which is your Medicare and Medicaid, and those are not negotiable rates as to what you get paid. But you also have your private insurance payers, which is a very limited amount of negotiation that our hospitals can do. Number 4 is flow of funds. This is different because we work through an intermediary. If you're selling a product, you have a price for it, that the consumer pays cash or credit card, and you have the money right there. With a hospital, you go through a whole process, submitting claims, getting it approved through the insurance company, and getting the price back from them, which could take on an average of about 60 days. So your cash flow is a lot different. Number 5, standardizing the product. Every one of us is different. And I use an example of this as trying to understand is a lot of times you don't understand the cost of what your service costs until after it was done. So, for example, you go in for a car, you buy a car, and you can say, oh, I want to have leather seats. Well, that's an extra $300. I want to have a sunroof. That's an extra $500. You know what your price is going to be before you leave the dealership. In a hospital, You go in for a colonoscopy and you can't say, I want 2 polyps removed. I want a dissection done for an extra $500. And I really don't want to pay for that cancer you may find, so go ahead and not do that. You just can't. So price transparency becomes really hard because you don't know how much it's going to cost until you leave the door and the actual service is done. So last one is establishing referral relationships. This is another regulation out there that makes it hard. And I use the example of Hallmark cards. If I was Hallmark cards, I'm going to go out and I'm going to find the company that produces the highest quality ink at the lowest price, and I'm probably going to contract with them to provide all my ink. And I may have a relationship with them for providing me that ink, that they will get exclusive rights to sell my product at a certain price. That is illegal in hospitals. You can't do that because of rules called Stark and anti-kickback. We can't build relationships with somebody that can do things cheaper. Okay, so hope that makes sense. Hopefully it doesn't. So let's move on then to this slide. This tells a great story for me. I love this slide. Nobody else does, but I do. This shows every organization, every regulatory authority that has some kind of regulation or legislative oversight over hospitals. H is in the middle. Those are the hospitals. You have, for example, CMS. You have your licensing boards of every single licensing board in your state. You have your Joint Commission, which is your quality legislation. You have so many people that can regulate hospitals. This, to me, tells a great story. So hospital finance is challenging. There's 3 terms you'll hear a lot. Number 1 is charge. Number 2 is payment. Number 3 is cost. Charge is what the hospital will charge. There's a methodology as to how hospitals determine their charge. They're going to look at how much aggregate, what the cost may be, make sure that they're, charging more than what it costs them to do the service. They're going to look at market prices. They're going to do a bunch of stuff to set their charge. However, that's not hardly ever what we're getting paid. We're getting paid the payment, which is what the payers, the insurance payers, have said they're going to pay us. The rest is a write-off. Number 3 is cost, and your cost, of course, is the actual cost of doing the service. So some things that you should know is that hospitals have to charge, and again, another rule and regulation, the same rate for every individual. No 2 payers pay the same. Government payers pay below cost with no negotiation. Commercial payers negotiate sometimes based on the market share. And lastly, there's charity care and underpayments that happen because we have to see everybody. Remember that whole thing? We can't turn anybody away as you can in other business. You have to see everybody that walks in their door, whether they can pay or not, okay? So moving on to that, hospitals, talk about the revenue side. There's 2 payers. There's the public payers, which includes your Medicare and Medicaid. And again, your Medicare is everybody, your people over the age of 65 and some with some disabilities. There's about 500,000 Medicare recipients here in Kansas. Medicaid is a joint between the federal and the state government for people that are eligible based on their low incomes and families and certain chronic conditions or disabilities. And there's about, on average, about 360,000 people in Kansas that are on Medicaid. And then you have the private payers. Private payers are your private health insurance. That's your Blue Cross and Blue Shield, your United Healthcare, your Cigna, your Aetna. All of those are your private insurance payers. Your health insurance market. And also you have self-payments that we put in this. These are people that do not have insurance. And like Chad said, that represents, and I know this is really small and you can look at it on your slide, but that represents about 10% of our patient volume is self-pay patients. About 60% are in that public payers here in Kansas. 30% are in that private section, and the rest are those self-pay, work comp, all of those kinds of things. So let's do an example here of just a basic x-ray. This is, again, we just took it off of a basic code. Just to kind of, if I would tell you the whole story, I'd tell you about the whole coding and how the bill works and this and that for the 5 months of learning in my class. But there's about 10,000 codes you can bill for services in hospitals. I just took a basic CPT code for a basic femur x-ray in 2 positions. It cost the hospital about $75 to do that x-ray. This is just one example of one hospital. We charged $110 for that service. Medicare will pay us $45 for it. Medicaid will pay us $24 for it. The commercial insurance we picked for this example paid us $93 for it. And self-pay, we don't know for sure how much we're going to end up getting paid. So that's a great example. I just wanted to show you how it can be different. The other one is an ED example of a Medicaid patient. And we talk here a little bit about you guys controlling a little bit more the Medicaid program here in Kansas. For example, a simple Medicaid evaluation and management of a patient, you have 5 codes that the physician can pick from when you come to the ER. 99281, something pretty minor, you came in to get a sticker out of your foot. 99285, you're either in cardiac arrest or you've had a major car accident. So they choose which one you're going to pick. We will get paid somewhere between $16.60 and $114 for that ER visit. So just to kind of put it into perspective, what reimbursement rates are. So revenue's going on. So just wanted to highlight real quick. Again, those public payers are non-negotiable. We take the fee schedule that they get us, and that's what we get paid. In 2019 here in Kansas, Medicare covered about 94% of the costs, which means our hospitals lost about 6% on public payers. And if you remember, we have 60% of our payers that are public payers. In 2019, our Medicaid payments covered about 84% of cost, which means that we lost about 16% on Medicaid patients here in our hospitals. So where does that leave us is an underpayment in our public payers, which means we got to try to make it up somewhere else, which a lot of times is trying our hardest to negotiate with the commercial payers. That is really where the only way that we can make up for those losses and to keep our doors open to see our patients. So just wanted to hit real quick on bad debt and charity care. Bad debt, again, is made up of all of those payers that do not pay their bill, which could be people with insurance. And that is kind of one of the bad things this last few years as insurance programs have gotten where you have high deductibles and puts a lot more back on the patient. It could be that $2,000 deductible that the insurance paid $5,000 for it, but you have an obligation to pay the other $2,000. So it could include that you didn't get paid, or it could be all those people without insurance, okay? And then charity care is what a lot of hospitals, nonprofit hospitals, are required to do charity care. Most for-profit hospitals also do charity care, but for those people that do not have insurance, they're going to discount their prices to get some sort of payment from them. Excuse me. And then lastly, I'll just hit on costs real quick. And really, I just highlighted the top 3 costs in hospitals. Number 1, of course, as you can imagine, is salaries, wages, and benefits. And that represents about 50% of what hospitals cost, the expenses. And if you can imagine, 80% of the people that are in our hospitals have some kind of higher education or have had to pass a licensing exam to do their services. They're highly trained people. So that makes sense as to why that costs so much. Supplies is number 2. And that represents about 20% of the cost of hospitals, and that includes any kind of the supplies you use, your drugs, food, linen, all of that service. And lastly is capital expenditures, and that represents about 10% of hospital costs. And I always tell the example of a CT scanner. You buy a CT scanner today, tomorrow it's obsolete. It is constantly being updated and made better so we can see that x-ray better. We can see what's inside your hospital, inside you a little better. With those capital equipment. So that is constantly turning as well. So, and then just a little bit of a statistic in Kansas in 2019, the average cost of a patient stay in a hospital was $2,191 per day. So that kind of concludes my part. And thank you. And again, anybody wants to take my class? Enrollment starting.
So with that, I know you can see that there really is a lot of work that we can do together overall to help with the financial sustainability of our hospitals. Of course, Medicaid reform is one way to address underpayments and cost shifts that are occurring in the market, but there are other things that are really driving up costs. And as Shannon and Chad both mentioned, staffing is a big part of that. Staffing agencies are absolutely critical in filling gaps when we need clinical skills, and we can share that expertise between our hospital healthcare systems and our healthcare settings. But there are some changes that could really help ensure that the structure of that relationship really is sustainable over the long term. And those options really do include potentially adding some transparency so that your hospitals know what they're competing with for salaries on a per employee per hour basis. Also addressing things like non-compete clauses that can keep potential workers out of the market for a period of time, as well as requiring that some of those folks that are working for those staffing agencies have provided really direct patient care to ensure that we're getting well-trained staff from staffing agencies, as it has been for decades in the state of Kansas. But there are a lot of other opportunities and ways that we can work together to address a lot of these workforce challenges. And I'll go ahead and turn it over to Jaron to talk a little bit more about some of what we've had in conversations with other states across the nation.
Thank you, Madam Chair. Thank you, committee, for having us. As Tara mentioned, my name is Jaron Caffrey. It might be a unique name for some of you, so you can think of that as Aaron with a J if that helps you at all. So it's great to be here, and thanks for having us. We're going to dive into a little bit of the picture of workforce in Kansas as it exists with hospitals. And we're really at a great time where, we're talking a lot about the issue. We'll paint the picture of the issue. But thankfully, you all are really able to help us and help hospitals in terms of, let's stop just talking about the issue. Let's really focus on some solutions. So we'll dive into a little bit of that today. So as you can see here, starting off, the nurse vacancy and nurse turnover rates. And this is from our data that we collect from our members. And so you can see nurse vacancy rates, that top little half of the chart there, a clear spike when we got into 2021. And what happened? Obviously, COVID was a huge driver of the 2020-2021 period. So you can see there, and I know it's a little maybe hard to read, so you can see the darker column is CNAs, that middle one is LPNs, and then RNs are on that right side, and that's same for the top and the bottom. And so you can see across the board for CNAs, LPNs, RNs, huge spike in vacancy rates, and that still exists today. So we're really, really short across the board on not having enough nurses, which really, nursing is the foundation of hospitals, of healthcare, in terms of when you have a patient coming in the door, they're the ones that, really, they help make the magic happen. And so we're sitting there, the number, if you can't see it, it's around 20, 21% there in terms of what the current vacancy rate is. Moving down on the bottom, nursing turnover rates. Again, there was a spike when we got into 2021. You'll notice on this, CNA, which is again that dark blue column, that's always been pretty high, right? And that's really because who are CNAs? Who are these patient care techs, which again, these are terms that we'll use interchangeably largely in hospitals. These might be, high school students working, in the hospital as a CNA or other roles. So this is more of an entry-level position, so there is always higher turnover. But you can see there for all of the roles, there was that spike in 2021. These graphics here represent the primary care shortage counties in Kansas and then also the mental health shortage areas. So the green on the left side is primary care, and you'll see about 80% of Kansas counties have primary care shortages. On the right, you'll see about 90% of counties in Kansas have mental health shortages. And especially on the mental health shortage areas, that really is a huge blend of urban and rural counties. So really no one is immune when you look at that picture. This slide can really help. Again, I'll describe some of these since I know it's hard to read, but this really illustrates that it is not just nursing that we're talking about here. These are the highest in-demand roles based off of vacancy rates in the state of Kansas. And so you'll see on the left-hand side, sterile processing techs is the highest, most in-demand role, about just over 24%. You'll then have LPNs, CNAs, RNs, of course, as we're talking about this foundation here. But then we go over to things like respiratory therapists, some various lab roles. So laboratory right now throughout the state is hugely in demand. There's many, many vacancies, and that's really a critical area of need at this time. Of course, radiology, pharmacy techs, this whole, there's so many roles that go into healthcare. It's not just the physicians and providers and nurses. All of these other ancillary roles are really critical parts of the care team that are also experiencing these really high vacancy rates right now in the state of Kansas. So it's across the board in healthcare. You'll see this graphic splits out rural and urban, some of the most top vacancies and turnovers based off of these two groups of counties. So you'll see they're pretty similar, right? Rural, urban, CNAs, RNs, housekeeping. Those are some of the most positions that turn over, and they have really high vacancy rates, both urban and rural. You'll notice, though, on the rural side, there's also the food service workers and dietary aides. So we're looking at this, and again, there are housekeepers on both the rural and urban side, but it's important to note that we're not just talking about our skilled workforce in terms of, needing to get a 4-year education or an advanced degree to fill some of these clinical roles. But especially in rural areas, you're having to compete across the board for the community when we're struggling with employees in general. Hospitals and other healthcare institutions are also having to figure out, okay, well, how are we going to have the people to run the kitchen? When you have folks that are inpatient staying over the night, you have to feed them. So there's that added consideration that rural communities really also have to deal with in addition to the clinical roles that we're seeing both on the rural and urban sides. So why do we have a shortage? How did we get here? Why is this such a bad issue? Obviously, as we mentioned, COVID-19 was a huge, it really exacerbated the issue. That was a clear problem. But there was absolutely workforce issues before the pandemic. Certainly, again, COVID made things worse and made it extra visible, and it's really just made the whole situation worse, where we're at today in the status quo. But we'll see, here down the list. Baby boomers retiring. I read an article earlier today. There's about 10,000 or more folks retiring every single day. A huge segment of the healthcare workforce has traditionally been made out of these baby boomers. So that's a direct hit to most hospitals that are facing, again, this added layer of making this workforce issue even more challenging. Desire for flexible work schedules. In healthcare, there's often, pretty tough hours you're having to work, 12-hour shifts, or you're on call, or this and that, depending on, if you're a provider, if you're nursing, or where you're at. So that's tough. It's really adding to this burnout that many folks in healthcare are feeling. New options like remote work and digital opportunities. As we're all aware, there's more and more jobs that you can sit on your couch throughout the day and work 8 hours and make a decent living. And that's great for people that can make that work. But again, that's just making this issue worse when we're having healthcare professionals that are really getting burnt out. They're not just leaving their workplace and going to work in other forms of healthcare. In some cases, sure they are. But we are seeing a lot of folks that are leaving the healthcare industry entirely. Salary and benefit limitations, as Shannon just mentioned, labor costs are really, really skyrocketing. There's only so much you can pay people, especially when hospitals have, it's not as easy as just, raking in new revenue by selling more services. When prices are capped, when you have certain revenue that you're going to take a loss on for some different patients or some different CPT codes, it's not as easy to get that revenue to really try and pay your staff more money. Education opportunities limited. Again, this is an added consideration for rural Kansas. It's hard if you want to try and maybe train a radiologist or respiratory therapist and send them away to maybe a school here in the eastern part of the state if you're coming from western Kansas. There's a chance you might not get that student back and coming back home to whatever county you're coming from. So you're losing those people. So the educational opportunities is a huge point to address. Patients often need more services, and then the bottom two here, communities lack spouse opportunities, but also childcare and housing. And this is both urban and rural. If you're wanting to recruit a nurse and that person has a spouse, you got to make sure that their spouse has a job opportunity wherever you're moving to, wherever you're recruiting them from. And then also childcare and housing. This is a huge issue, and this is really for all industries, right? If you're wanting to recruit anybody, housing is becoming more and more unaffordable, and again, it's harder and harder to find. Same with childcare. Affordable childcare or even childcare at all, there's not enough providers. And so we're really having this issue of added considerations, especially as you're wanting to recruit students coming out of colleges. This really makes that hard to do, especially in specific parts of the state. So last slide here, and I'll turn it back over to Tara. So really, what does this actually kind of tangibly look like on the bottom line? And so you can see, looking at bedside RN, just as an example, the average cost of turnover for a bedside RN is about $46,000. So sure, when you go to LPN and other roles, that number will come down, but looking at the RN, that's a lot of money. That's really a salary for some other folks. It's not the salary for an RN, but that's an FTE really. That's just the cost you're paying for turnover. Each percentage change in nursing turnover can save a hospital about $262,000 a year. That's a lot of money. When hospitals are having 20% or higher turnover rates, that's a lot of money that adds up if you're able to really try and drive those turnover numbers down. And lastly, this data point here, really interesting, it's really powerful. Hospitals nationwide have lost an estimated 105,000 employees, and the shortage of new nurses is projected to reach 450,000 by 2025. It's climbing. It's climbing. There was articles in the 2010s that were saying, by 2030, we're going to have, these shortages, we're going to have these issues. Well, it's coming up to 2025. Really, we're experiencing it now. And it's just continuing to get worse. And so that's why it's really, really important now more than ever that we really look at, have a solution-oriented mindset to address these issues. Because if you lose hospitals, if you lose these folks, those are communities that have to suffer and patients that don't get as good of care. And so really had a great opportunity now to address some of these things. And again, it's not all doom and gloom. I know this is scary stuff. It is unfortunate stuff. But really, I think we're at a great turning point to be able to address these things. So I'll pass it back over to Tara.
Thanks, Jaron. And I think one of the things that we have really been focused on at the association is exactly what Jaron said. Okay, so we have this problem. We recognize that it's a problem now, but also a future problem that we're going to have to deal with. So what are possible solutions? Because coming to you with the doom and gloom is not really helpful. So some of those immediate things that we think about is, as Jaron mentioned, retention is on our mind. Obviously, protections for our healthcare workers, but also in addition to that, creating incentives to get people interested in nursing education. So the Kansas Nursing Initiative is a program that provides scholarships for nurses across the state administered through the Board of Regents, so increasing those. In addition to that, we know that there are a lot of nurse educators that can make so much more bedside. As we've talked about here today, the landscape has changed in what those folks are making. And so really being able to retain those nurse educators is a key part of keeping nurses coming into our hospital systems, but also establishing new scholarships for some of those higher levels of nursing becomes critically important. So to keep our nurses engaged and wanting to become nurse educators so that we can build out that pipeline becomes very, very critical for us. So that's something we think we would like to see. In addition to that, when we think out a few years, we know that there's really a need to get young people interested in healthcare more broadly. One of the things that we see playing out when we think about young people is they think about two tracks. They think about doctors and they think about nurses when it comes to healthcare. But as Jaron mentioned, we need non-clinical staff. We need IT folks. We need attorneys. We need all of those folks in a hospital system. So investing in programs that really develop early interest in all kinds of different fields as it relates to healthcare. One of those programs is the Health Occupation Students of America, which is a HOSA program, which has chapters all throughout the state, we think could be very helpful. In addition to that, developing apprenticeship pathways for when we look at both looking at an entry-level position, some of those CNAs and LPNs that Jaron just showed you some graphics around, taking someone who maybe is non-clinical then also retaining them by getting them educated and paying them while they're getting educated through apprenticeships. Other states have seen some significant success. So we look forward to talking with you all and our regulatory agencies about what a solution around that could look like in the state of Kansas. With that, we know that there are a lot of things happening beyond these walls here in this building that have impacts on how you all are talking about this. So to talk a little bit about what's going on at the federal level and some of those conversations, Audrey Dunkel's here to give you a little bit of an update.
Thanks, Tara. Well, you all look like you've been drinking out of a fire hose and a little stressed out. So the good news is I get to talk to you about the things you really can't do anything about. The only thing that you need to know is that these are also challenges for hospitals. And oops, there we go. First on that list is sequestration. So in 2011, Congress passed legislation that said we are automatically going to cut, in order to balance the budget, different programs. Sequestration for Medicare is 2%. That is slated to go through, I believe, 2031 at this point. So since 2013, there has been a 2% reduction. And that number for 2022 was $18.8 billion out of the Medicare program. Now remember Shannon's slide, 42% of payers on average are Medicare. So lopped off 2% off the top of that automatically. That continues to be a challenge. The public health emergency unwinding, of course, is creating some uncertainty because we are going to see people roll off the Medicaid rolls. We don't know what that's going to mean for what it looks like in our communities. We know there will be regulatory changes, and there's some regulations we'd like to see continue, and there's some we'd like to see go away. So we don't know what that is finally going to look like when we get to the end of that. Next then is, of course, regulatory burden, and thinking back to Shannon's chart about how many organizations regulate hospitals. Again, when we look at that, we know that every time there's a new regulation, that just increases the costs of providing care. And so we are always fighting that tension between patient safety and what is just costing patients more but not providing a larger benefit for them. And then last but not least, Chad talked about the rural emergency hospital program, public health emergency, rural emergency hospital, and looking at getting that implemented. And what do those regulations look like? How are hospitals going to be paid? Because as hospitals look at that as an opportunity, the big question is, is that going to be financially sustainable? Because that's why that choice is being considered. So just a little bit there on the federal level. Certainly, if you have questions about those things, we are available to answer those, but I'm going to turn it back over to Tara to finish up for us. Thank you, Madam Chairman.
We appreciate the opportunity, and we appreciate the opportunity and look forward to working with you in 2023. We've included a slide that has all of our contact information, including Audrey and I's cell phone numbers, and we're happy to be a resource for you beyond today, but we look forward to answering your questions in addition to working with you in 2023 and beyond.
All right, committee, do you have question for any of our presenters? And if you hold back, that's on you. So, Representative Bryce.
Hi, thank you. I had a question. The rural emergency hospitals is fascinating to me, and I guess that's a relatively new program. Can you tell me, is the advantage for facilities doing that a reimbursement advantage? Is it a reduction in regulatory burden? What's the incentive for hospitals or facilities to become rural emergency hospitals?
Sure. There's a couple things related to that.
Each time you guys come up, if you'll tell us who you are because of our WebEx.
Yeah, Chad Austin with the Kansas Hospital Association. So the rural emergency hospital is just a more effective and efficient way for some communities to be able to offer that type of care. And so really looking at what are the areas that are most needed in that community and leaning into those services. So it's going to be more on the outpatient side, looking more at the emergency room services, taking out the inpatient services, not necessarily needing those services within that community. It is a different type of reimbursement structure. There will be a component that has a kind of a grant feature of roughly about $3.2 million for that hospital, and then the other parts of the services are going to be paid under a different reimbursement system. So it's kind of a mixture of each.
Just real quickly, are there any other innovative programs for rural hospitals that might be coming down the line that might be able to help them?
Well, a couple things, so the rural emergency hospital is probably the most creative and innovative one that's out there right now. There are other ways that we're looking at, as Tara mentioned, like through telehealth and different things like that, broadband, looking at how can we keep as much of the care locally as possible and working with those communities to be able to serve those patients. Yeah.
Well, and as we progress through this year is, I'm sure we'll hear more about the rural hospital. It has been something that's been worked on. Your association's been working on a federal level as they have across the country. We've been harping that it needs to happen because as hospitals in our rural areas get smaller, they were losing out big time. So this will be a lot of advantages for them. Further questions? No one else? That's it? Well, I'll get Representative Epley, and then I'll come back to you. Representative Epley? Okay.
Thank you, Madam Chair. Chad, this is for you, and I didn't know if you really covered this. What percentage of our critical access hospitals are in financial jeopardy, as you would define it, and what percentage are healthy financially?
Well, this is Chad Austin with the Hospital Association. So that's a great question, Representative. And there's a lot of different studies that are out there in terms of how they define at-risk hospitals. And I think the most recent one came out that indicated there was about 55 at-risk hospitals within the state of Kansas. Those definitions vary from report to report. We've seen about 7 hospitals close over the last, I think it's been about since 2010, but it really is it varies from report to report in terms of how they define that. But the most recent one that we've seen indicated there's about 55 hospitals in Kansas.
Okay, Representative Reese, and then I'll come over to you, Representative Barth. Or, excuse me, I'll go to Representative Turner and then come to you, Representative Barth.
Okay.
Go ahead.
I have a question. My question is about hospital finance 101.
You're taking the class?
I would love to actually take that class. I know way too much about this. Regarding with the hospital finance, regarding, federal regulations about the no surprise billing piece, where are we with that?
So Shannon Flock with the Kansas Hospital Association. So the No Surprises Act, so the last part, it was implemented in January 2022, the first phase of it. And that first phase was a price transparency part for hospitals. So hospitals had to have certain things listed on their website, including a detailed list of all of their charges, what their reimbursement was for every single payer. So that was in January 2022. So that was the price transparency part. And then there was the No Surprises Act part, which is a little bit different. That included that we had to do good faith estimates for patients that did not have insurance or came in and said that they would not be using insurance, and we're trying to do good faith estimates. So that started in January 2022. However, the federal government allowed us, part of that good faith estimate is that we are supposed to be giving an all-encompass good faith estimate, which includes when you come in, a lot of times if you have surgery, you'll not only get the bill from the hospital, but you also get a bill from the anesthesiologist, or you'll get a bill from the pathologist, or you'll get a bill from some other service. So the all-encompass good faith estimate was supposed to include all of those. They allowed us some leniency because that's hard to do. A lot of times hospitals don't know how much or don't see that other bill for the pathology or the anesthesiology or something like that. So they allowed us through 2022 to figure out how to do that. And we've been trying to come up with processes on how to do the all-encompass bills, and hospitals have been working on that. It was supposed to go in place into January 2023, and they delayed that because they found out how hard that is to do. So they have allowed us some leniency with a date that has not been set yet to continue working on how to interface our computer systems and things like that to do an all-encompass good faith estimate. The hospitals are attempting it. You should still get a good faith estimate when you come in if you're self-insured. It just may not include that all-inclusive part. So,
Thank you.
so I hope you bet.
Representative Turner?
Thank you, Madam Chair. Please stay up there. Same question. Question to you also. As you went through the financials, you mentioned that the first block, 60% of your folks get through Medicare and Medicaid. You're losing, or only getting about 90%, so you're losing 10% of those. And then the next block was the self-pay and the insurance folks. You're getting 84, which you're losing 16%. So, and then you said the third group was where you make it up, and I'd missed that.
So your third group, of course, is your private insurance payers. It's your commercial insurances that you're attempting to negotiate. So it's what is a term called cost shifting. You may hear that every once in a while. Sorry, I didn't introduce myself again. Shannon Flock with the Kansas Hospital Association. But it's a cost shifting where you're attempting to negotiate with those private payers to not only, negotiate their service, but attempting to make up a lot of that cost that you know that you're automatically losing from your government payers.
Madam Chair, thank you. So how quickly do you pass through? So they were talking earlier about, we're in a period of very rapidly rising costs. So how quickly do those rates get adjusted in all of these categories, I guess, because they're all based on negotiated rates, correct?
The private payers are.
Well, the others are not negotiated,
Government
but they
payers are
set
not
rates.
negotiated. Those are set rates. You get a fee schedule that is proposed rules come down once a year to where those rates from your Medicare organization gets changed once a year. Your Medicaid, a lot of times it depends on, when the state legislature changes rates. Otherwise, those do not get changed. We have some rates with Medicaid that haven't been changed since the 1980s. So that's your government payers. Your private payers, it depends on your contracts. A lot of times hospitals we try to tell hospitals to try to redo contracts every other year, every 2 to 3 years. So you're attempting to renegotiate every 2 to 3 years on your private payer contracts. As when I say the word attempting, is a lot of time it's hard. It is really hard to get insurance payers to negotiate their rates. It's attempted, not always successful.
Thank you, Madam Chair.
Representative Barth.
Thank you, Madam Chair. This question is probably directed to Chad Austin. I think you had mentioned that hospitals are closing at a certain type of rate. And my question is about hospitals that are also opening. I'm seeing quite a few opening and being built as well as expansions. Can you talk a little bit about what that looks like in comparison and maybe what's happening in the world of hospitals?
Yeah, I would say it's a little bit all over the board. Again, this is Chad Austin with the Kansas Hospital Association. So, the hospitals that we've seen close over the last probably 10 to 12 years have been more in the rural settings. Most recently you've seen some down in southeast Kansas with the closure of the Fort Scott Hospital, the closure of the Independent Hospital, down south central Kansas, the closure of the Wellington Hospital. Those oftentimes are, partly the challenge is that those are more large rural hospitals where they don't have the volume maybe that an urban hospital has, but they also don't have the different payment structure that a critical access hospital has. Those hospitals were a different type of facility. There have been some hospitals that have opened here recently. Most recently in those circumstances, it's going to be more in those areas of growing population. We've seen that out in the Johnson County area. We've seen some expansions related to that, and that's really due to the geographic shift that we're seeing in the demand for services. Yeah, thanks.
Chad, if you'll stay up there. When we had the discussion about Fort Scott when they shut down, it's and correct me if I'm wrong, but it's very possible that had we had this rural hospital designation, that there may have been a possibility of them staying in place because, you're better explaining this, but it has to do with the number of beds that are required for inpatient, that kind of, can you elaborate on that just a little bit about why this rural hospital deal is different than what we've had previously, which explains why it's so important to us in rural Kansas?
Well, as I mentioned earlier, the Rural Emergency Hospital Program is just now getting underway in 2023. It did pass in 2020. At that point in time, the federal statutes basically indicated that the new rural emergency hospital designation would only be available to those hospitals in existence as to the passage of that legislation, which was back again in 2020. Some of the hospitals that have closed prior to 2020, so Independence, Fort Scott, the hospital in Horton, Kansas. I know there's been some conversations about are there opportunities to get federal laws changed to allow those hospitals the opportunity to become a rural emergency hospital. We are working with our congressional delegation. I know Audrey and our team back in Washington are working with our congressional folks to see if there's opportunities to allow recently closed hospitals to participate in the REH program. But again, you know, it's largely due to the types of services that are needed. And oftentimes, as we put this program together over the last dozen years, communities and hospitals talked about the need for access to emergency room services, access to the ancillary services or the outpatient services to ensure that they had those. Those were the areas that were most of interest, and then working and partnering with neighboring hospitals to provide that more acute care services.
Because if I recall correctly, on Fort Scott, they ended up having another entity come in, and it's run now as a section of it as an ER for the community, correct?
There is some of that in Fort Scott. There's also in Independence. There's also another hospital that has put in some services. There's an emergency room now that's down in Independence, Kansas as well, and provides some outpatient services, which is kind of similar to the model that we're looking at with this rural emergency hospital.
Okay. Committee, are there further questions? Representative Hasswood.
Thank you, Madam Chair. My question is on the getting newer workforce into the line. I don't know if that might be Tara or Jaron. You talked about the Kansas Nursing Initiative program. I thought there was a Physician to Rural Kansas Initiative program with KU Med. Can you talk a little bit more about, is that still, or what's the progress on that? And how are we working with our technical colleges? I know in Lawrence we have like Peasley Tech who does nursing, and tapping into high schoolers. High schoolers now are finishing early and have semesters or years than the normal track, just because things are shifting.
Absolutely, yeah. So great question. Jaron Caffrey with the Kansas Hospital Association. So starting out with the first about the KU's program with physicians, and so I don't want to get into too many of those details since that is something they do, and I think I don't want to misrepresent anything that they do with that program, but it is very similar. You can think of it as almost like the Rural Opportunity Zone program in terms of being able to recruit physicians with the requirement of then working in rural areas, and then those students would get part of their education paid for or forgiven, and that kind of a thing. So there is that program that exists for physicians. I don't know that there's so much anything for other roles down the line in terms of other things. Again, you could use something like the Rural Opportunity Zone program, but there isn't necessarily a similar comparable program, if you will, specifically built for those professions. I will share, so you mentioned engaging high school students and that kind of thing. So Tara talked about HOSA, and so this is something, it's you think of it really as FFA for healthcare, or FBLA, FCCLA, depending on where you went to high school, those types of things. It's a career and tech program built into the high schools as an extracurricular activity, and so we see that as a great opportunity to engage those students, because a huge issue is we need to make sure that we have young people interested to fill the seats of these programs, right? I mean, if we don't have people wanting to go into healthcare, that doesn't do us any good in terms of building that pipeline. So there's opportunities like that, and we're working to expand more programs so that we can really engage students more. We do work with the community colleges and tech colleges on a few different things. we're looking at stuff like apprenticeship, which is what Tara mentioned, that being a good opportunity to engage those groups specifically, because it really is a win-win for helping fulfill the workforce needs of healthcare institutions, while also that is education that students would be going through that might not otherwise go through if there wasn't an apprenticeship program. So there are those opportunities, but of course always looking to collaborate in any way that we can.
Well, and I can also tell you, Representative, is that we've had several of the interim committees, the mental health bed committee that we had is looking at workforce, Care Oversight's looking at workforce, or, we've reached out to our partners with our education department, with our regents, and people like the hospital associations and everything is, how can we grow this? And it has to start in our schools. And so, anyone that's got ideas, they just need to, present them to them. There's no such thing as a crazy idea, and it may sound crazy in the beginning, but sometimes crazy ideas get you to what really actually works. And as you heard Chad talk about earlier, we knew that this workforce shortage was happening. So people act like we're just now jumping on it. Well, no. We've been trying to look for a long time, but COVID expedited everything. We had people that were at retirement age that were still working, and they said, hey, I'm not doing this. This is too much. I'm going to go ahead and retire. We're also looking at people that want to come back into the workforce that say they decided to be a stay-at-home mom and got out of their nursing field. How do we make that coming back in and reinstatement, to where we're not blocking them from being able to come in, that we're putting roadblocks up for them? So any ideas taken, bring them. You'll hear us talk about it at some point in here. I don't know what that looks like right now, but bring them to us. Representative Blex.
Thank you, Madam Chair. A question for Chad. Have you seen? He has to say who he is first. Pardon?
He has to say who he is first at the mic, please.
Okay.
Yeah,
Who
this
are
is
you?
Chad Austin
Okay,
with the
thank
Hospital
you.
Association.
The question being, has the rural hospital concept been in place long enough to see that there's a savings in our workforce problems as far as less workforce compared to a hospital? And being from Independence, seeing the closure, loss of 190 jobs, but that was basically Mercy's corporate decision. They spent $1 billion on a hospital in Joplin, and I went through those sad times and heard a lot of stories. But when Labette Health come in and put what I affectionately call a transfer station, it give us our emergency room and the ability to get in there. And actually, they put it in almost a ag area of the town, on the western edge of town, next to a farm store. Not where you'd find a hospital normally, but it appears it's working very well. Mm-hmm. And, there's not the competition for high dollar imaging equipment between two hospitals 10 miles apart. But yet they seem to be growing. Do we know at this point, is there any savings in this workforce issue that shortage we're dealing with, or is it too early to tell that yet?
Well, there's probably a little bit of too early to tell related to that, but that model that I know Brian Williams out in Parsons is doing in Independence is something that's very similar to what this rural emergency hospital program looks like, because it does provide ER services. It provides a lot of ancillary outpatient services. It doesn't have any inpatient beds or what have you. And so that model is really kind of very similar to the model that we've been working on that just now got approved a couple years ago by Congress that is now rolling out in 2023. Now, will that have different types of a workforce need? Yes. Does it mean that there could be maybe some more efficiencies associated with that? I think those are the things that we're kind of working through and visiting through this new concept.
Okay. Thank you for that.
Yeah.
Representative Vaughn.
Thank you, Madam Chair. My question was for Tara Mays. I was wondering, you talked a little bit about the observation of involuntary mental health patients, and I know that's something we've kind of talked about the last couple of years, and you mentioned reimbursement, but I'm wondering, long-term observation hospitals and also in jails is probably not the ideal place for those folks to be. Is there conversations about what we need to do to ensure we can have better outcomes? Is that increasing beds in mental health hospitals? What's kind of that side of the conversation?
This is Tara Mays with the Kansas Hospital Association. Appreciate the question, Madam Chair. So I was referencing specifically a mental health observation program that I think gets at a couple of components of your question. You all have done a lot of work around mental health in the state of Kansas over the last couple of years, whether you're talking about CCBHCs or mobile crisis centers. There's a lot of work being discussed. And as a part of the Mental Health Interim Committee, which also spoke about the addition of beds, they recommended, as we've talked with our partners, a mental health observation program because there's a recognition that these patients, once they have been assessed, identified that they are involuntary patients for a state hospital system and they are sitting in either our ERs or in our county jails, the recognition is that it's probably not the clinical care that that patient needs to be getting, and really it's more 24/7 patient observation that has to happen. And while previously, if you think about years past, maybe even not that long ago, that was being done by our law enforcement community, even in a hospital setting. But as this workforce challenge sort of grows beyond our hospital walls, those shifts continue to happen. So I do think, to your question about clinical care, that is a big part of the reason why we see this as a good interim step, and why it hopefully is maybe a barometer to see if some of those other investments that you all have made are working well.
Representative Clifford, and then this will be our last question.
Thank you, Madam Chair. Tara, if you'd stand back to the podium. You made a presentation on prior authorization and how vexing that is for hospitals and for us physicians. I think you really could have made a better case because it's really bad. And the feds have been unable to deal with it. So we have an opportunity in the state to deal with it. Some states have had gold passes and other things to enable automatic approval. What do you see as some things we could consider here this year for Kansas?
Yes, Madam Chair, Tara Mays with the Kansas Hospital Association. Appreciate the question. I did mention prior authorization, and as our hospitals have kind of taken a look at it, there are a few components that are really maybe the priority items that we've talked about. One of those being the timelines around prior authorization. I mentioned it takes on average our clinical care from our survey says 1 to 5 hours per prior authorization. So setting some parameters to get that sped up, but also I mentioned really streamlining the process. So a lot of what we're talking about at the federal level is really making it more electronic friendly. I mentioned fax machines and phone calls, and that was absolutely accurate of what we're hearing happening in our hospitals. The other component about that that we're hearing from our hospitals is sort of the appeals process that happens. So there's the prior authorization process that happens initially, you get denied potentially, and then you have to go through a peer review process. Sometimes those peer review processes are not ideal. So for instance, you might have a clinical specialty that is a cardiologist speaking with a clinical professional that's more of an OB. And so the question is that a real peer-to-peer consult? So creating some parameters around what that peer-to-peer consult looks like, in addition to creating an express button. When you have a clinician or a physician that knows that this is a complex enough case that we need to be able to push the expedite button and get to that peer-to-peer consult very quickly, we think that could be helpful. And you mentioned this, but I think we are interested in, for those that already hit the 90% threshold, some states have said you shouldn't have to seek prior authorization if you've already hit that threshold. And so we're interested in having conversations around all of those parameters as a way to really deal with this process and prior authorization. And I look forward to having more conversations with this committee about that.
Thank you, and thank you.
Well, and I think, too, there's a difference in terminology between pre and prior authorization. It can all get very, very complicated. And committee, as you'll see, I'm not infallible. I will make mistakes, and so I do apologize to Representative Blex, but I jumped the gun on it. But I'm actually blaming Representative Reese. She was supposed to stop me, but she didn't do that. So, okay, committee. Committee, you can leave your folders here, and most of us do, so that we don't have to cart them back and forth. Dave picks those up, puts them in a file cabinet, so if you ever needed them, you can ask him where they are put at. He will put them out for you at each meeting. We do try to finish at around 3 o'clock. Occasionally, we will go beyond that if we're just in deep discussion, because most of us will have 3:30 meetings after that, and there'll be committees coming in behind us. And if I don't see you and you're wanting to ask a question, please make sure you look at Representative Reese or Representative Epley, and they'll acknowledge you, and we keep a running list so that we know who's next in line. But don't be afraid to wave if none of us have looked at you or acknowledged you, because occasionally we all get kind of busy on other things. So I want to thank everyone for their attention today and being here. We're on next Tuesday with, do you remember who that is, Dave? Okay, he doesn't, so we're in good shape. But we will have 3 days of committee hearings next week, or not hearings, but just information 101. Oh, I know who it is. It's actually DCF and KDADS on Tuesday with Secretary Howard and her staff. That's who we will have on Tuesday. So at that, we're adjourned.